Do you place ceramic restorations or zirconia restorations? Do you ever have one come off? Do you ever have one break? We're going to discuss exactly those problems today and how to get around them. Hi, I'm Dr. Michael Miyazaki. Now, when I was in dental school, we did a lot of gold restorations, gold crowns, and we'd burnish the margins of the gold up to the tooth and seal everything up pretty much just by bending the metal and burnishing it against the tooth. The cement basically just filled in the space. We tried to create very retentive preps. We'd have grooves. We'd try to make sure that we had as parallel prep as we could, maybe 6 degrees of taper. Well, with the new restorative materials we have, like lithium disilicate and zirconia, we can have these aesthetic restorations, but sometimes we're challenged. We need to have enough occlusal thickness so that our restorations don't break. So we may need to have enough tooth reduction so we have the right aesthetics, because we're all after aesthetics. Sometimes I'll do an onlay where my margins are very high, not down to the gingival margin, but very high. So I don't have a lot of retention on either the buccal or lingual sides all the time. So when I'm using these materials, what I do is I bond my lithium disilicate, Emax, and my zirconia type restorations all the time. So I follow the same protocol. And I want to kind of go through today and discuss why I would do that and some of the other considerations that we all have when we're dealing with these types of restorations. Now, the patient comes in, they've got the best of intentions, but do you ever get that call where the front desk hears from the patient, a crown came out? So on my schedule, I see re-cementation. I'm thinking, oh, that's never fun, right? The patient's not going to be very happy. And I don't know if they do this because it's just what they think or if they're trying to make me feel bad. But typically it's, hey, doc, this came out when I was eating a piece of bread, something soft. It wasn't something hard. It wasn't something really sticky. And we tell the patient, well, it probably wasn't the last thing that you're eating, but over time, because you chewed on this 100,000 chews, it's gotten a little loose. But we try not to have that happen. We understand that it's a real inconvenience, and it's just something that's not even good for our practice. So we try to prevent it. So when we're prepping our tooth, we try to make sure that we have adequate retention. Now, in the past, we'd put grooves. Today, I try not to do a lot of grooves. I rely on the retention with my cement, my resin, to help retain that restoration. I still try to have as much parallelism in my prep. I want to make sure my walls are as parallel, but yet have a draw. But by bonding my restorations on, I get not only the physical retention, but I get a chemical retention that helps me keep that restoration on. Today, if I have to remove a ceramic restoration, like an Emax restoration or a zirconia type of restoration, many times we have to drill the whole thing off. We're really getting a good bond. So that's what I want to do, is I want to make sure we have a good bond. How do I know this? We had a patient that came in last week. It was tooth number 2, the upper right second molar, and he had a crown. And on that crown, this guy is a clincher and a bruxer. And he said, ever since, as long as he could remember, he's been told by his dentist that he's a clincher and a bruxer. And we had placed a crown, about 8 years ago on him, and it was a lithium disilicate, an Emax type of crown back then. And it was very short tooth, and I explained to him as we go further back in the mouth, the teeth get shorter, and because he's a clincher and a grinder, his teeth are even shorter yet. He could really use a full mouth rehab, but he's just not going to do that. So I work with the tooth structure that he has. So he came in and he fractured off some of the restorative material off of the tip of the lingual cusp. I wasn't going to try to repair it. It was just going to be very hard to repair. So I told him it'd be better if we take this crown off and we'll go into a zirconia crown. Now, as I was prepping this tooth out, I was doing more occlusal reduction to make sure I had thicker material in the occlusal of that tooth. You know what? That restoration, could have probably served us longer than maybe 8 years, but with his clinching and grinding, I was probably lucky I got that much time. But the next restoration I place, I want to last even longer. Now it's a second molar, and so as I prep that second molar to give me more thickness of my material, my preparation is getting shorter. So again, I'm thinking I have an internal ferrule, I have an external ferrule, and I'm going to bond this on chemically. How did I get the internal ferrule? Well, fortunately for me, this tooth had a root canal. So where the access opening was made, there was a composite core buildup. So I took some of that out. So I have an internal ferrule of about 2 millimeters. So that helps me create more parallelism because I've got the external walls of the prep and the internal wall of that where I prepped into the core itself. So I have more retention. I explained to the patient, hey, these teeth are very short. His teeth are very short. On the distal of the tooth, I have about 1 millimeter of tooth height left. So this is a different patient, but a very similar scenario. Second molar, lower right-hand side, patient comes in, it's broken. I always look at the material. Was it thick enough? This material was about 1.5 millimeters thick. This is lithium disilicate. But we know that this tooth undergoes a lot of occlusal stress. In the past, I mentioned that when I was doing a gold restoration, many times I'd cement. So I would try to make sure I had adequate prep height, parallelism, maybe some additional grooves to help create more retention. Today, I might cement zirconia restoration if I'm in an area where I cannot isolate that area well, where the gums bleed, or maybe there's going to be a lot of salivary contamination back there. I may just elect to cement that restoration on and go with zirconia. Some of you will cement your restorations because it's what you prefer to do. It is probably a little bit easier, but I like to bond my restorations on. So when I look at the preparation, I want to make sure that as we prep, we have adequate reduction, sufficient axial height, and then round the internal line angles out. So like this is on a type of dump, but just showing how we don't want to have a lot of sharp internal line angles, especially with the zirconia restoration that's going to get milled out. Why? If I have a very sharp corner and that's going to be milled out, the diamond that's doing the milling can't create that sharp corner. So what's going to do is it's going to create kind of a looser fit in that corner, give it itself a little bit more room. It's going to do the best job it can, but it's got to make sure that the restoration fits the prep. So it can't create that sharp corner, so it's going to kind of over mill it. I don't want that to happen. So we're going to have as much parallelism as we can have. We're going to have to round off the internal line angles and have adequate occlusal reduction. Now another important thing is when we scan this, we can't scan a bloody prep or if I have a lot of saliva around that area. So I need to get that area to be dry. I might use a laser and do laser the soft tissue to control the bleeding and to create separation between the soft tissue and the hard tissue. And that's what we did here. So you can see there's a definite physical separation between the hard tissue and the soft tissue. And then as kind of an adjunct to that, I'll use QuickStat Free. And I've mentioned QuickStat Free before. I love, it's a hemostatic agent that's a clear hemostatic agent, but gives me really good control over any areas that bleed. So by controlling that area, we're able to scan and get a nice clean scan. Now, when I get the restoration back, what I'm going to do is I'm going to try it in. But when I try the zirconia restoration on, we're going to have salivary contamination there. So what I'm going to do is I'm going to try it on, check my contacts, check the bite, check my margins to make sure everything looks good. Then I'm going to take it out. I'm going to rinse the saliva out of that zirconia restoration, air dry it. And then I use a chair side air abrasion unit just to kind of clean the internal surface out. And then I use ZRC. It's a cleanser that will remove the phosphates. So I have this little inoperatory air abrasion unit that just kind of pops into the handpiece, quick disconnect. And if you want to use a little micro cab so the dust doesn't go everywhere, if you're doing this in your operatory, you can do that. So just showing you how we clean out the internal aspect of our zirconia restoration, again, after it's been tried in. Now I use ZRC. ZRC is a universal cleanser to clean, whether it be a ceramic. I use the same protocol for my Emax and my zirconia, and I can use the same for my metal restorations. But I typically will get the bottle, and it comes in a syringe or a bottle. But I'll typically use the bottle. And what I'll do is I'll dispense a couple drops of ZRC right into my restoration. Sometimes use a little microbrush just to spread it around, just to be sure that I wet the entire integular surface. Allow it to dwell there for about 20 seconds, and then I rinse that out with water and oil-free air. What I like about ZRC is the bottle. You don't have to shake it before you use it. So I got my ZRC. I just put a couple drops like you see that I'm placing in this crown. I agitate it to make sure I cover the entire integular surface, and I rinse it out. Some of the other cleansers I use, they have different colors. It might be a blue or purplish type color, and sometimes when you rinse that out, it's hard to get the color out. This orange color, like you see on the far right-hand side, just rinses right out, and there's no residual color left. Why are we doing this, especially with the zirconia? Zirconia will be contaminated by the phosphates in the patient's saliva. So when we try this in and we pull it out, we look at the internal aspect of our zirconia restoration, and it's coated with saliva. That has phosphates. Now if I try to bond to that, I'm not going to get my maximum bond strength. So this chart on the lower left-hand side has been created by using the machine on the right-hand side. That is an X-ray photoelectron spectrophotometer. And what we're able to do is we take zirconia restorations, contaminate them, then measure how much phosphate's left on the sample. With the control, you can see that it's got 100% contamination. We use another cleanser that I use for many years, decades, IvaClean. It removes about 23 to 25% of the contamination, but there's still phosphates left behind. The Vista Apex Universal Cleanser that you see right here removed everything. So here on these little discs that you see on the lower right hand side, those little blue purple dots represents contamination. On the far right hand side, we can see that the ZRC Universal Cleanser removed all the contamination, which just means we're going to get a stronger bond. So I've got this restoration that's very short, so I want to get the maximum strength I can when I bond that to the tooth. So I use a lab. They give me a restoration that's going to require no adjustments, either interproximal or occlusal. We have adequate thickness, so I have maximum strength, and we're using an aesthetic material. It's contaminated. I take that restoration out. I'm going to air braid it in the operatory just to clean it. Then I'm going to clean the phosphates off with our ZRC, and then I'm going to dry the internal aspect of the restoration, and then I'm going to prime it with ZRP, as zirconia primer. Now ZRP, we place it inside the restoration, and then I'm going to not rinse it out. I'm just going to thin it with air until it doesn't move. The surface will look shiny on the inside, but it won't be rippling with the air. Why do I use ZRP? Because ZRP improves the bond strength of our zirconia to the underlying tooth, as you see in the chart on the lower right hand side. All right, so I apply 2 coats of ZRP and I dry it thoroughly. So I apply the ZRP, usually I just drop it straight into the restoration. Then I spread it out with a little micro brush and then let it dwell for a little bit, and then I dry it thoroughly with oil-free air. Now that I've got it cleaned and primed, we can apply universal adhesive to the internal aspect of the restoration. I apply it, again, spread it out with the micro brush, and then air thin it. We're trying to remove the solvents and the water from our adhesive, so we thin it out very thoroughly, and then you can place it in an area where it's not exposed to intense direct light. Now we go back to the mouth. We would then take that tooth, control the bleeding around the preparation. So I use QuickStat Free. I just go around the preparation. It controls the bleeding and the crevicular fluids, like the saliva from coming up from the sulcus, because it's an astringent. And then I rinse that off. Then I take my Velvet Etch, which is our purple etchant, 40% phosphoric acid. I apply that to the preparation. Let it sit there for about 15 seconds, then I rinse that off. So I tell the patient we're cleaning the tooth because we don't want any bacteria underneath our restoration. Now as our cement, we're using the Regen resin cement. So it's going to be a dual cure cement. Because it's dual cure, I bleed the syringe to make sure we have base and callus coming out. So on the far left hand side, you see I bled out the dual barrel syringe to make sure that the base and callus are both coming out. Then I put the tip on and I bleed a little bit out of the tip. I use that little bit that comes out as kind of a way to gauge the timing. But that just helps me ensure that when the base and callus come out, that the portion of that I place into the restoration is completely and fully mixed, because I never know how well that first part's going to mix up. So I just put that first 1/4 inch on a little pad, and then as I'm getting to my set time, I'll kind of push on that to be sure that the cement is hard. Then we'll place the cement into the restoration. We'll seat it down firmly. Then I will take my pink wave curing light. Now the pink wave curing light I really like because it's got that large lens. But what I don't want to do is I don't want to cure all the cement. Remember, it's a dual cure resin cement. So I take the edge of that lens and I place it on the buccal side typically, where I overlap the margin maybe with 1 or 2 millimeters of the light, and I shine the light for about 3 to 5 seconds. All I'm trying to do is I'm trying to tack the cement just so it sets at the margin and that restoration is not going to move. I don't want to cure all the cement yet, because then it makes the cleanup take a lot of time. So what I do is I just tack set it, then I go back and I wipe off all the gross excess. I floss inapproximately on the mesial of this restoration that we see in this photo. Then I can go back, once I'm sure I got all the gross excess cement off, then I'll do my cure. And again, what I like about the pink wave curing light is that it's got the large lens, over 12 millimeters large. So when I'm trying to cure like a crown or an onlay like on this molar, the entire occlusal surface is covered by the pink wave. And so I just cure it for about 20 seconds. I know it's set. Now sometimes I'll go in and do buccal. Sometimes I'll go back and do a little bit more on the lingual. I like my dual cure cements just well done. But you know, if I went in there and I cured this for 20 seconds and it was a dual cure cement, then I would know that I should have it very well cured and set. So there's the restoration. We clean it up. There's not a lot of excess cement. Then I adjust the bite and polish up any edges, and we are good and ready to go. And even though this is a very short preparation and restoration, this restoration has been there for years and we have not had any problems. This tooth, being a second molar, has taken a lot of occlusal forces, and I just feel like by bonding it on there, we have more strength in the restoration. I hope this gives you some tips that you might incorporate into your bonding of your zirconia restorations or your Emax restorations. And I hope this protocol helps you so you don't have them coming off and so you don't have them breaking. This is a great opportunity for all of us to be in this community of like-minded individuals. If you like this program, hit subscribe. If you picked up a tip here or there, share it with a friend. We're colleagues sharing information to make our professional lives easier. And I hope it's making our personal lives better too. Really enjoy having you here. Thank you very much. And I'll see you again soon on another video. Thank you.